Welcome to the Luton Primary Care Network's presentation. My intention here is to cover three main points by the end of the presentation. Number one, what PCNs are. Number two, where we sit in the NHS health structure. And number three, how we are an important link between community and health and vital to integrated neighbourhood working. My name is Farhanda Mahmood. I'm the manager for Phoenix PCN, one of the 6 PCNs covering Luton. Phoenix are proud winners of the HSJ Patient Safety Awards 2025, which recognise outstanding achievements and innovations in improving patient safety across the UK healthcare sector. They are among the most respected accolades in the healthcare community, celebrating teams and organisations that go above and beyond to protect patients and improve safety standards. Out of 456 entries, 25 winners were selected nationwide by a panel of expert judges. So an excellent achievement putting Luton on the map. We tend to blow this trumpet at any opportunity we get because we are very proud of this achievement, as we are a relatively small local organisation up against large trusts, ICBs and hospitals who are heavily funded and heavily staff resourced. When you Google PCNs, you get this picture, even though they've been around since 2019. The acronym PCN stands for Primary Care Network in the healthcare sector, and originally it was like an unofficial coming together of sorts of a group of GP practices in a bid to reduce workload pressure between themselves. But as the landscape has evolved, PCNs have become more and more independent and are working towards becoming legal entities in their own right. Now, imagine a scenario not too far from the current reality where we have a healthcare crisis in the country, a gloomy metaphorical climate where unfortunately waiting times are over 2 years for certain outpatient appointments. We see a system where urgent no longer means urgent, rapid response no longer means rapid response. Mental health services are abysmally failing the needs of the population. Mental health stats are at record highs. Picketing healthcare staff feeling undervalued and overworked. Burnt out primary care teams whose manpower is diminished in the face of demand, and patients losing trust in the system when delays cause escalation and whole population health is deteriorating due to lack of timely intervention and support. For many, this is not just a hypothetical scenario, it's a reality for both professionals and patients. Imagine now the picture of a healthy, vibrant, cohesive, integrated community. Maybe they're on an island or coast off the tranquil Mediterranean. Everyone is connected. Everyone has good health literacy and are able to manage their health, or everyone knows where to get support from when they can't manage themselves. Empowered individuals and therefore vibrant neighbourhoods and strong communities, being cared for by a cohesive health and social care team who see the individual as unique and not as a statistic, addressing them as a whole person, a truly patient-centred care model. Everyone wants to be there, don't they? Imagine now each of our 6 PCNs as a mode of transport, the essential connection and conduit to getting us to that destination. One may be a plane, a ship, a train or a car. We are different in our structure, but we are all heading in the same direction. Our goal is the same. This Luton map brings together 4 newly established neighbourhoods, 23 GP practices, 7 branch surgeries and 6 primary care networks, collectively serving almost all of Luton's 275,000 residents approximately. With every registered patient covered by a PCN and no duplication across our databases, we have a unique, comprehensive view of the healthcare needs of our entire population. GP practices hold some of the most extensive and valuable health records available, capturing lifelong patient information that is continuously updated through direct care and interactions across the wider healthcare system. This gives us unprecedented insight into our communities, allowing us to address demographics, health conditions, medications, test results, vaccinations, and much more. The real power of this data lies in what it enables us to do. By identifying specific patient cohorts and with a clinical understanding of where health needs are greatest, we can target interventions more effectively, address health inequalities and deliver proactive care where it can make the biggest difference. This population-wide approach provides a strong foundation for improving outcomes and creating healthier communities across Luton. So let's start at the beginning with a backdrop of struggling GP practices and appointment demand and access issues that you've all probably heard, read or experienced. Things have changed a little now with online access and total triage, but up until quite recently we typically heard patients saying that there were never any appointments, and that was if you could get through on the telephone line in the first place. There was a general feeling of staff not doing enough. I've heard patients say, my GP says he's always busy, but whenever I go, the waiting area is empty. What is he busy with? And other comments about receptionists being gatekeepers or dragons. Is it surprising then that we have an opening attitude of frustration? A negative perception leads to negative communication, and a negative expectation fosters negative relationships, a snowballing of sorts. Now this picture aptly demonstrates the work done in practices. Patients, press and the wider public do not see the targets and contractual requirements, long-term condition reviews, the administration, scanning, coding, referring, form filling, the reviewing of results, bloods, discharge summaries, the vaccination and screening drives, the meetings, the peer reviews, supervision and training, and the list goes on that doesn't cover even half of it. I was a manager in a GP practice for over 15 years, and almost every day was spent responding to immediate problems, complaints, emergencies, staffing issues, deadlines or operational challenges. This forever firefighting was the reason I left my role. I hope that I have illustrated to some extent now that there is so much more that happens below the surface. So this should make it easier to see from the practice perspective. Practices see a population increase, which means more work, a funding decrease, which means harder work, a decrease in GPs, which means less ability to meet the escalating demands. There's a disparity between primary and secondary care budgets where 70% of funding goes to secondary care, but 70% of the footfall is in primary care. We have constant landscape redesign, which makes it difficult to make long-term plans. A lack of estates and physical space where expansion has been actively discouraged in the contracts. We have negative press outlook, which is very demoralising, pouring fuel onto the fire. Exhausted and burnt out staff and an unhappy workforce. And we all know you cannot pour out of an empty cup. So in this chaos, the PCNs were created in a bid to support this mismatch in demand and access and provide some alleviation to the practice workforce. Now, this pyramid demonstrates the care delivered to a patient in various stages of their health situation. At the top of the pyramid, you have those patients at advanced stage of poor health, where the maximum that can be done has already been done, and now plans and processes are in place to make their journey as comfortable as possible. The green section below, think hospitals, advanced diagnostic procedures and specialist treatment from consultants and teams, addressing reactively a healthcare need, a treatment for example, MRIs, surgical procedures like amputation, it could be treatment like dialysis when the kidneys have failed, or chemotherapy to aggressively treat a cancer. The blue section is where GP practices sit. There is a proactive element to the work that they do with screening programs, vaccination schedules and long-term condition reviews. But this has since COVID become more and more difficult because sheer demand has caused general practice to become more reactive. Essentially though, they escalate to hospital when a problem is outside of their remit and de-escalate into community with management and treatment, like for example prescribing antibiotics to treat an infection. And then there's us, the PCNs, providing practices with staff resource to help meet demand where needed, but more geared towards a preventative model, looking for the inequalities and population needs, raising awareness through education early so that the problem doesn't arise in the first place. Desmond Tutu said we need to stop just pulling people out of the river. We need to go upstream and find out why they are falling in. And if we think of the flowing river as the whole NHS system, with the patients requiring care, treatment and support, then that river is already overflowing. And PCNs, with their neighbourhood approach, are best placed upstream, on the bank in fact, taking this quote a step further, because by raising awareness and improving health and well-being, we aim to prevent people falling in the first place, because prevention is better than cure. This is just a basic illustration of Luton practices sitting under their relevant PCNs. So what do PCNs do for the GP practices, and what do they do for the individuals, staff and patients? Through our services, we provide additional appointments helping alleviate pressure on staff at GP practices. There are lots of ailments and conditions our staff can support with, freeing up valuable GP time for more serious patients. Through our wider projects, we address health inequalities. For example, from national health data, we knew that within our PCN, dementia diagnosis was lower than the national average. Remember a few slides back I talked about demographical data held by practices? Well, in a bid to address this underdiagnosis, we carried out assessments with our clinical team on all of our housebound patients, patients who cannot get to their GP practices, mostly due to immobility. We diagnosed 25 new dementia patients. Getting timely diagnosis means we can get the correct treatment and put right management plans and processes in place in a timely manner. With our prostate cancer project, we focused on a different cohort of patients because we know that men of Black Afro-Caribbean ethnicity over 55 with a family history of cancer are more at risk of getting prostate cancer. There were roughly 300 patients, only half engaged with the project. For the 150 so odd who did engage, we screened, tested, reviewed and referred onward to hospital ourselves, confirming diagnosis of 9 new cancers at early stage. These patients didn't think to book an appointment with the GP. Their symptoms hadn't warranted it yet. Early diagnosis means early treatment and better prognosis. Through our multidisciplinary teams, we provide patients with holistic, individualised, patient-centred care. For example, one patient was referred to our social prescription team for long-term anxiety. A deeper conversation with our health and wellbeing coach revealed that she had not left her home alone for 20 years. She even had a family member with her at her appointment. She could not go to social gatherings, and this social isolation was impacting her self-esteem, to the point she could not make eye contact. She was getting hallucinations of insects crawling around her or on her, and this impacted her psychologically. And over the years, from lack of intervention, the anxiety had escalated to panic attacks, in turn elevating her blood pressure, so much so she was clinically not permitted to drive by the consultant. And a lack of social activity was causing weight gain. With an MDT approach, we looked into the medication she was taking with our pharmacy team and changed her meds. We connected her to social prescription for employment support. We coached her through her anxiety and improved her confidence so much that she proudly told us at an appointment 6 months later, which she had arranged for a totally different reason, that when she had gone shopping for the first time on her own, it had shocked her family. With her anxiety now managed, her blood pressure became more controlled. She now had a job as a school minibus driver and had lost weight without even trying. But her telling us this with full eye contact and a genuine smile on her face was the kind of priceless you cannot put into words. So we help practices by providing vital resource via our trained clinical and non-clinical staff. Last year, the practice's Phoenix covers alone provided 48,000 extra appointments to their patients with our staff. We have specifically trained clinical staff in basic life support, minor illness, frailty, diabetes, diet and lifestyle advice, medicines management, physios, coaching and behaviour change, and we provide nurse and GP appointments in the evenings and weekends to support additional demand as well. With our social prescription, we connect patients to charities, groups or organisations to address their social needs, and that works in the opposite way as well, connecting groups and organisations to our patients. We collaborate with organisations where we can see a synergy in our goals and outcomes. Let me draw you a picture of exactly how. As you know, we address health inequalities with projects like the dementia and prostate cancer mentioned before, but we also do that via group support, building resilience and sustainability into our communities. Post-COVID, post-isolation and shielding seems like a lifetime away now. We identified many of our elderly in shielding cohort were suffering from loneliness, isolation, depression and anxiety. So we set up a coffee morning group to bring these patients together, because building connections with people facing the same challenges is always easier. This group recently celebrated its 2nd birthday, and if you were to attend, you would never think that they had ever had any symptoms of depression and anxiety from the buzzing room with their wide smiles, warm hugs and loud chit-chat over coffee and tea. This established group, now called the Phoenix Fridays, asks for education and information from our team, and that's how one morning we connected with the Lewis Foundation. Now, the Lewis Foundation, for those of you who don't know, are a charity which supports cancer patients in hospital, providing them with care packages at a time when they are the most vulnerable and isolated. And we can all understand how that helps those patients feel valued and cared for in hospital. Now, our Friday group heard their presentation and were galvanised to help with volunteering. But with an age range of 78 to 98, mobility and transport was a challenge. So we facilitated collaboration between the two, and as a result, what we now have is the care packages being made by this group over tea and biscuits. The feeling of contributing to others in need is the kind of warm and fuzzy that really improves your health and well-being. So patients in the hospital are feeling valued, the charity is being supported with a free labour of love, and our group is contributing back into community and expanding their connections. We have various other collaborations with established organisations such as Community Interest Luton and Giving Back. We work with streets to provide group exercises at various locations. Nothing beats a bit of chair-based exercise to Michael Jackson's Billie Jean for improving the circulation. Streets has enabled 4 of our team to get the training needed to deliver exercise sessions ourselves. Both our groups and staff love them, a win-win all round. So this is a collage of some of the photos our team have taken, and you can see medics and Equality PCN staff in some of those too, because we do all work well together even though we are covering different patches. I could talk endlessly with everything we at Phoenix have been doing. Our team have been very busy and we do so much more that I have not been able to cover everything, but hopefully you've got a flavour for some of it. The other PCNs will have similar stories and case studies of their own. The pictures are of education and awareness sessions and some of the events that we've attended. Our main areas of focus are health and well-being in diabetes, mental health, behaviour change in diet and lifestyle, the elderly and frail, improving cancer awareness, supporting charities like Macmillan in our cancer awareness drives, or fundraising for charities like Race for Life. Some of what I've mentioned is specific to Phoenix. The HSJ achievement was a result of our special interest in diabetes and mental health. However, different PCNs are at different levels of maturity. Different demographics means different focus and priorities. Different list sizes means different funding and therefore different staff makeup. And different skills mix means different services. But we are all funded by and adhere to a national PCN DES contract, so there are some fundamental consistencies in our work, and we are all heading in the same direction. We might be travelling in different modes of travel, but the destination is the same. By bringing together multidisciplinary teams, PCNs expand the range of services available in the community, improve access to care, and support people with complex and long-term conditions. Our general focus is on prevention, proactive population health management, and collaboration with other services to address health inequalities, reduce pressure on hospitals and GP practices, educate and empower, and improve the health and well-being of our neighbourhoods, communities and town. Understanding what PCNs are, why they were created, and what they do is essential for appreciating how the NHS is evolving to deliver sustainable, high-quality care for the future. Please check out the websites and social media of your relevant PCN for more information. We have some really good educational videos that we have just started working on, and the website and social media are our best means of communication to patients and the public, communities and organisations. We regularly update our social media platforms with events or workshops or even new initiatives we are planning on. This will be the case for all the PCNs across Luton. How else will you know what we are up to next? Or if something that we're doing could be useful to you, a friend or a family member. Maybe it could be just what you need. Thank you very much for listening all the way till the end. I hope that this has increased or at least improved your knowledge to some degree about primary care networks in Luton, what they are, what they do, and how they are the natural conduit between health and community and vital in the integrated neighbourhood model.